I'm sort of struck when I sit with a patient and I talk about them going on a BTK inhibitor based therapy as their frontline therapy, and they'll ask me, well, how long is this going to work? And in the frontline setting, I have to say, well, I don't really know. Because of the long-term, even the long-term data we have, we don't know what the median is in terms of progression-free survival. So we've never been in that type of situation before. Let's move and switch gears a little bit and talk about BCL2 inhibitor-based therapy, venetoclax. Venetoclax is approved in the frontline setting, and that was based on the CLL14 trial. And we have seen some recent updates with regard to CLL14. Maybe Dr. Shadman, you can sort of summarize what we know in the frontline long-term follow-up from CLL14, maybe a little bit about what the trial design was and what it showed.
Sure. So CLL14 study, in my opinion, is one of the most important studies for CLL. Basically, it brought a time-limited and non-chemotherapy or chemotherapy-free treatment in the first-line setting, and I think that that's very important for our patients. So basically, this study was done by the German CLL study group, and patients with comorbidities defined as a CIRS score of more than 6 or kidney function with a creatinine clearance of less than 70, they got randomized to receiving either venetoclax and obinutuzumab as combination for a fixed 1-year duration, basically without any role from MRD in terms of stopping the treatment. So everybody got 1 year of treatment, starting with obinutuzumab, and venetoclax was added to it, and the control arm was chlorambucil and obinutuzumab. So the primary endpoint of the study was progression-free survival with MRD overall survival and response rates as other endpoints. It's important to mention that 12% of patients roughly had an abnormal P53, either mutation or deletion, and 60% of patients overall had an unmutated IGHV gene, and kind of not different between the two arms. The initial report that we had from this study showed that the study, of course, met the primary endpoint with a 3-year PFS of more than 80%, 82% in the Ven-G or Ven-obinutuzumab arm, and the chlorambucil obinutuzumab had 50% 3-year PFS. The benefit was seen all the known risk groups for CLL, including TP53 abnormal or unmutated IGHV gene. And so here, because we're talking about the fixed duration therapy, then the depth of response becomes very important. So one of the important endpoints of this study was the rate of MRD elimination. So on peripheral blood, patients who received Ven-G, 76% undetectable MRD when they, with the sensitivity of 10 to -4, and in the bone marrow was 57%. And so this is very impressive, because what we know from Ven-based therapies and also with this study is that the duration of response and progression-free survival is directly correlated with the depth of response, meaning that if you achieve that undetectable MRD, the PFS would be longer. And what we saw in the recent meeting at ASCO, we saw that 18 months after finishing therapy, 47% of patients on the Ven-G arm were still in the undetectable MRD status, which is very impressive. Again, for the CLL14 study, we don't have the actual estimates like we do for Murano, that like what is the exact PFS for each category of undetectable or low MRD or high MRD, but we know that they're significantly different. And so again, unlike the discussion we had about the BTK inhibitors are that, you know, achieving an MRD or adding a second agent really doesn't help the overall benefit. And I agree that the benefit is not necessarily PFS. Here with the Ven-based therapy, we are in a very different situation, because the goal is to give a fixed duration therapy and stop. So it does actually matter how good that response is. And I think the most recent follow-up at ASCO showed that this undetectable status could be actually durable. We also had some info. Well, we're still not seeing any new safety signal with the current follow-up, which is important. And there was some report of secondary malignancies, which the numbers, I believe, in the 17% range for the treatment arm versus 10%, but mainly skin cancers. And I don't believe that there was any concerns from what I reviewed that there is a specific type of secondary malignancy that's more prevalent in the treatment arm. So overall, as I mentioned, this now gives us an opportunity of offering a treatment that's that finishes at some point, and it's not chemotherapy. Now, as part of the conversation that you mentioned, kind of trying to decide between maybe BTK inhibitors or venetoclax-based therapy, one of the factors that we consider is that this is a great treatment, and we talked about some of the benefits, but it's not as easy to start as what we have in BTK inhibitors, which is basically, as we were talking during the COVID pandemic, you can sometimes start somebody in treatment without even seeing them. I mean, hopefully that won't happen, but it's not impossible. I mean, you can follow somebody's labs and start a patient on treatment. In venetoclax, you need teamwork. You need a lot of coordination. There is risk of tumor lysis syndrome, and there are strategies that we have to follow to decrease that risk. One would be really picking the right patient. If you have a patient who's not able to follow the recommendation in terms of coming to the clinic and follow that ramp-up protocol, or they have an unstable kidney function, maybe this is not the best treatment option for them. But really the strategy of debulking the patient, like the CLL14, one of the differences between the CLL14, which is the Frontline study, and Murano, which is the relapse study, we'll talk about it later, I believe, is that here we start with obinutuzumab, and with this approach, from the lymphocyte count standpoint, we're able to downgrade these patients in terms of risk of TLS. And in real practice, sometimes in patients who have significant bulky disease that may not be adequate, sometimes you add more time to that antibody or do other strategies. But in general, even following the CLL14 schedule and regimen, as long as the ramp-up protocol and the standard practice, which I follow religiously, and I think it's very important until we have data. Otherwise, we have to follow it, because as great of a drug that venetoclax is, we don't want to deal with a situation that we have a tumor lysis that is not has been preventable. So yeah, this is a new option for us, and as part of the conversation is that initial phase of debulking and ramp up that we have with patients.